बाकी खा लो। तू चुटका वाला जो खा लो। चुटका वाला कौन सा था? खाना तो चुटका वाला नहीं है। ये जवानी होगा। उसको तुझे लगता है कुछ नहीं। खा ले में 2 काट। अबे तुझे नहीं खाना, नहीं खा ले। तो खा लिया मैंने। चुटका वाला जो खा लो।
Oma, 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 Oma. Hello, good evening. Can you hear me? Hello.
Yes, yes.
Good evening, everybody. So we are ready to start our Wednesday webinar of the Indian College of Anesthesiologists. And it's a pleasure to have such a senior faculty with us. For those who do not know much about ICA, though I'm sure with these webinars you've all come to know about the Indian College of Anesthesiologists, this is an academic body which deals with all the educational aspects of the country, of the students of anesthesiology. And we are trying that we should have equal status in the whole country. And for this, we have our own college with its own website, which you can all go and read about it. We have about 1,500 members, and we appreciate if the youngsters join this, because in the long run, it's going to benefit all of them. We have been having these webinars for the last 1 year, and we have been holding it every Wednesday, and most of you are joining it, and most of the students, the feedback that we get is that they are very helpful. And we have the Anesthesia TV, Mr. Rahul, who also is helping us, and he is relaying this webinar every week at the same time. And there are a whole lot of viewers in that as well. The topic that we have chosen today is advances in anesthesia practice. Because if you see, the topics that we have selected are on liver transplant, but these are the topics which have not been covered earlier. If you remember, we had liver transplant webinar a few months back, in which we covered the kidney transplant and liver transplant. However, if you see these topics, they are very different, in which we have pediatric solid organ transplantation. Pediatric was not covered in details that time. And so also the incidental surgery in patients with who have undergone solid organ transplant liver. And for that reason, these are important for the students, because they come to them, these questions or these areas come to the students as questions, as well as to the practicing anesthesiologists who are doing this in the tertiary care center. And of course, we have added artificial intelligence in anesthesia, which is the in thing. And for these, we have, for all these 3 lectures, we have very eminent speakers who will be introduced by the moderators. The moderators themselves are very senior members of our faculty, of our fraternity. And to introduce them, we have 2 moderators, Dr. Murlidhar and Dr. Archana Kaul. Dr. Murlidhar is a very close friend of ours. He's a senior consultant and the academic coordinator of the Apollo hospitals in Delhi. And he has been there for several years, and he has many credits to to be told and to be very proud of. He is the ex-associate professor of AIMS, but he has joined Apollo since a long time. He's the elected member of the National Academy as well as the elected fellow of the Indian College of Critical Care. And secondly, we have Dr. Archana Kaul. She's a senior consultant in the department of Sir Gangaram Hospital, which is my department. And she has a keen interest in pediatric anesthesia and liver transplant. And both Dr. Murli and Dr. Archana Kaul, of course, have several national and international publications, and they have contributed to several chapters. So thank you very much, Dr. Murlidhar and Archana Kaul, and they will now be introducing the speakers, and we start the webinar. Thanks a lot. Dr. Murli, please.
Yeah, thank you, ma'am. At the outset, I'd like to thank all those senior faculty of the ICA, and especially Dr. Sood and Dr. Radhakrishnan, Dr. Anesthesia, and all of them who have organized this ICA webinar. At this point, I would like to take this opportunity to welcome everyone to this academic feast, which is actually 3 interesting topics and which will provoke us to redefine the possible. What it means is we are in the mindset of the difficult and the impossible when it comes to newer topics, but our speakers will take us from this realm of difficulty to what is possible. As we all know, a lot of centers across the country have a considerable experience with adult transplants. But the pediatric solid transplant is a new ballgame. It requires skill, organization, resources, and execution, which are very difficult in our country. So the first 2 lectures by Dr. Meja and Dr. Vemi will take us through this journey from problems to possibilities, and they let us know where we stand today. The 3rd lecture is by Dr. Ashish Malik. And this is on artificial intelligence, which is a highly disruptive technology which has been introduced recently into the realm of anesthesia. It raises very serious questions today about the future. What will happen to us? Will we have our jobs? What will be the impact on anesthesia? Will it lighten our burden? So these are the questions which Dr. Ashish will try to answer. And now I invite Dr. Archana Kaul, who's my co-moderator, to introduce the speakers and start off the program. Thank you.
Good evening. Good evening, everybody. So the first lecture is on anesthesia. Am I audible?
Yes, you are. Yeah.
Yeah. So the first lecture is on anesthesia for pediatric solid organ transplantation. When we talk of pediatric solid organ transplantation, we're actually referring to complicated surgeries in complicated age group. An anesthesiologist's nightmare if things don't go well or as planned. Our first speaker is Dr. Sanjeev Aneja. He's an eminent transplant anesthesiologist with immense experience of more than 25 years in this field. He has a fellowship in liver transplant anesthesia and a number of national and international publications. Dr. Sanjeev Aneja.
Thanks, Dr. Kaul. Thanks for the introduction. And Murli, you started very well. The pediatric solid organ transplantation is not done in many centers, but the number is gradually increasing. I had connectivity problem at home. Therefore, last night, I recorded my lecture and posted it to Sinesh, and Sinesh is going to play. Sinesh, please play the lecture. Good evening, everybody. I am speaking on anesthesia for pediatric solid organ transplantation. Solid organ is defined as internal organ that has firm tissue consistency and is neither hollow, such as the organ of gastrointestinal tract, nor liquid, such as blood. Heart, kidney, liver, lung, and pancreas come in the definition of solid organ transplantation. We all know that organ transplantation is a well-established treatment for end organ disease. The number of pediatric organ transplantation is also increasing. There has been considerable improvement in graft and patient survival following solid organ transplantation in children. Transplantation in pediatric age group is not only life extending, but life enhancing. Kidney and liver are the two organs which are more commonly transplanted in children. Today, I am going to discuss the broad anesthetic management of these two organs and how it is different than that of pediatric. First successful pediatric kidney transplantation was done in 1966. More than 1,000 kidney transplants are performed per year in children in USA. The incidence of end-stage kidney disease in children is not very high. It is approximately 14 per million in the pediatric age group. In adult, end-stage kidney disease is mostly because of diabetes and hypertension, whereas in children, obstetric uropathies and congenital anomalies are responsible for kidney disease in younger children, whereas focal segmental glomerulosclerosis is responsible for kidney disease in older children. Both hemodialysis and peritoneal dialysis are used as renal replacement therapy in children. Peritoneal dialysis is used more commonly in children as compared to adult because there is difficulty in taking the venous vascular access in children, and because of low circulating volume also, it is practically difficult to maintain hemodialysis in children. More patients come for transplantation in pediatric age group because of preemptive when they still have some residual kidney function as compared to adult, because it is difficult to maintain dialysis and there is a better outcome and favorable growth after organ transplantation. We do not have an organized registry in India. Therefore, it is difficult to know about how much pediatric transplants are done in India. This paper in 2017 tries to answer this question. According to them, there are 7 to 8 centers, mostly in the private setup, which do pediatric kidney transplantation. And these centers also do not do more than 4 or 5 in a year. Therefore, approximately 40 to 50 kidney transplants are done in India. The reason for this low transplantation number in India is there are not many pediatric nephrologists, and the involvement of public sector in the pediatric kidney transplantation is not there. Most of the organs in the West for pediatric transplant come from the adult deceased donor because they have a concept of share 35. And according to share 35, if there is a cadaver who is less than 35 years of age, the kidney of that cadaver should preferably be given to a recipient of less than 18 years of age. NATO, which controls the organ donation in India, doesn't have a share 35 concept, and it only says that the organ for cadaveric donor below 18 years of age to be offered to pediatric patients preferably. But it is of no help because cadaveric donors less than 18 years are usually very less. Most of the organs for pediatric kidney transplant come from living donor, and most of the time it is parents who donate the organ. If we go into the anesthetic management of pediatric kidney transplantation, we need to understand the pathophysiology of renal failure in children and its effect. And we also should know the specific anesthetic requirement in this group of patients. As in adult, we expect a dramatic alteration of fluid and electrolyte balance. They can be having hypervolemia, hypovolemia, hyperkalemia, and hypocalcemia, etc. The chance of this fluid alteration is more in children as compared to adult because significant number of these patients are on peritoneal dialysis, which is not very effective in maintaining the internal environment. And secondly, sometimes there is a preemptive transplant when they are likely to have these dramatic alteration of fluid and electrolyte balance. Congestive heart failure in adult is more commonly because of hypertension, whereas in children, the congestive heart failure is more because of hypervolemia. Anemia is equally common in adult as well as children, and all of them are preferably should be on recombinant erythropoietin to reduce the incidence of severe anemia. Uremic encephalopathy leading to seizures and global depression is seen much more in children than in adult because first, peritoneal dialysis is not very effective in removing the toxins, and second, the blood-brain barrier is not that impermeable in the pediatric age group. Nutrition is a big problem in the perioperative period. They suffer from renal osteodystrophy. There's increased chances of fracture. They need to be looked after carefully during the perioperative period. The surgical technique is also different in adult and children. The pediatric patients more than 25 kg of weight, the position of the kidney is transplanted in the similar way as in the adult. It is transplanted in the retroperitoneal space, and the anastomosis made to the ileal vessels, side to side or end to side. But in the smaller children, or less than 20 kg, it is placed in the abdomen after having a vertical incision, and the anastomoses are made to the aorta and inferior vena cava. Preoperative assessment, the preparation of these patients is same as the adult. Like adult, we need to evaluate the fluid and electrolyte status of these patients. We need to go through the post-dialysis electrolytes report. We should estimate the dry weight of the patient, and we should identify the fistula site so that the proper care can be taken during the perioperative period. Anesthetic management is similar to that of adult in the older children. They require standard ASA monitors. The large venous access of the peripheral veins should be sufficient for the older children for the kidney transplantation. But for the younger children, especially less than 20 kg, we need central line, and arterial line is must, because there is going to be clamping of the inferior vena cava or aorta, which have the hemodynamic consequences. Choice of anesthetic agent is same as that of adult, that we choose the agents which are not dependent upon the kidney for their metabolism. The anesthetic management requires some special requirements which needs to be taken care during the pediatric transplantation. These patients need higher than normal mean arterial pressure to ensure the adequate perfusion of the kidney. And if it is a small child, the unclamping of the aorta or the inferior vena cava can lead to hemodynamic instability. The size of the kidney is bigger as compared to the size of the baby. Therefore, the large quantity of blood can be shunted into the kidney, resulting in hypotension. There can be abrupt changes in the blood pressure in the smaller children. And the small children, when you place the kidney intra-abdominal and the space is limited, and you are giving more of the fluid, because a lot of the fluid is being shifted into the kidney, they require post-operative elective ventilation till it gets settled, whereas the older children can be extubated on the table. This is the broad anesthetic management of pediatric kidney transplantation. And now we move to the liver, which is one of the most common solid organ transplant performed. And the pediatric organ transplant is a more organized program. And in India, probably 100 to 150 transplants are done. It is said that for any high volume center or any high volume center, the 5 to 10% patients transplanted are less than 18 years of age. Biliary atresia is the most common indication of liver transplantation in small children, especially child less than 1 year of age or less than 10 kg. In older children, it is acute liver failure or tumor, which is the cause of transplant. Over the period of time, pediatric liver transplant has progressed a lot. There are centers all over the world and in India who do high volume of liver transplant, and they have made a team and they are giving very good results. Because of the team, more patients, more sicker patients are being accepted for pediatric transplantation, more younger patients are being accepted for transplantation, sick patients less than 3 months of age, or the patients with the involvement of heart or inferior vena cava, which were earlier being refused transplants, are being accepted for transplantation. The perioperative management of pediatric liver transplant consists of one of the most important thing in the preoperative period is optimization. Any center who is used to do liver transplantation would recognize that all the patients of biliary atresia would present you like big ascites, whereas after surgery it is very rewarding after surgery. This slide is not to show the brilliance of surgeon or anesthetist, but this slide is to show the importance of optimization with the help of pediatric transplant team. And the optimization consists of two important aspects, that is a nutritional support, and they all require very aggressive enteral nutritional support or the parenteral nutrition support is required, and the second is treatment of infection. Nutritional treatment of infections. Patients of biliary atresia have the history of ascending cholangitis. They have a history of repeated hospital infections. They have a history of repeated line-related infections, and all these things need to be taken care because before they are taken to surgery. And they suffer from very resistant infections which need to be taken care of. Therefore, optimization of nutrition and treatment of infection is the core point before the patient of biliary atresia are taken for surgery. Anesthetic management during intraoperative period is same as that of adult. The liver transplantation is usually divided into 4 steps. That is dissection, which is from skin incision to the explant of the liver, and it has all its problem like blood loss and the loss of fluid, and then the anhepatic phase. Anhepatic phase is especially important in the pediatric age group because anhepatic phase, when there is no liver, no glycogenolysis taking place, there is a chance of hypoglycemia, and the children are very sensitive to hypoglycemia. Their brain is very sensitive to hypoglycemia. Reperfusion and biliary anastomosis as in adult. Anesthetists involved in pediatric liver transplantation should be very well aware of 3 important aspects, that is the venous access, fluid management, and the coagulation. Venous access can be very challenging in the pediatric liver transplant patient, and it requires expertise and the use of ultrasound. This is very important. Coagulation monitoring is the unique requirement. Most of these patients would have previous portoenterostomy, and they are very likely to bleed in the dissection phase. But on the other hand, the coagulation has to be treated very carefully because procoagulants can lead to hepatic artery or the portal vein thrombosis, which can be life-threatening in these patients. And as a result, the viscoelastic method has to be used for transfusion of procoagulant in these patients. Fluid management is very challenging. There is need for advanced hemodynamic monitoring, which is not possible and which is not available. Cardiac output is, we initially thought probably the cardiac output in the young children is dependent upon heart rate, but now we know that the stroke volume is also responsible for changes in the cardiac output. Therefore, there is need for advanced hemodynamic monitoring, and which is not available for this age group. Central venous pressure or other static indicators are very poor in assessing the fluid responsiveness. The dynamic indicator, especially the flow track, which we use in the adult, is not licensed, or it has not been studied in the pediatric age group, and we cannot use, and pulmonary artery catheter in the smaller babies cannot be put. Therefore, there is a limitation of using the advanced hemodynamic monitor. In spite of this, there is a need of good fluid management, and probably what can be done is taking the frequent blood from the central venous and see for the venous oxygen saturation. That could be an indirect method of finding the cardiac output. Fast track is also getting very popular in the pediatric liver transplantation. The immediate or early extubation in the pediatric liver transplantation is possible nowadays, and it is associated with reduction in complication and reduced stay in the intensive care unit. Thank you very much.
Thank you, Dr. Aneja. You've touched some important points regarding transplantation of liver and kidney in pediatric patients. Going to our next lecture. The next lecture, as we all know that long-term survival after transplantation has improved over the years. So it makes it likely that most of us will be delivering anesthesia to post-transplantation patients coming for incidental surgeries or surgery related to their transplanted organs, either in emergency OT or in elective OT. So our next lecture is anesthetic management for incidental surgeries in patients with solid organ transplantation, and the speaker is Dr. Bimi Riwari. She is a professor in Department of Anesthesiology in All India Institute of Medical Sciences. She has special interest in hepatobiliary and liver transplantation anesthesia and number of national and international publications. She is an accomplished anesthesiologist and a very wonderful speaker. Over to you, Dr. Bimi.
Thank you so much, Archana. Am I audible?
Yes, Vimi, yes, you are.
Okay, ma'am. So I'm going to be talking about the anesthetic management of incidental surgery in patients with solid organ transplantation. And then in the next 20 minutes or so, I'll go through a brief introduction and next talk about general consideration in patients who have undergone a transplant and are scheduled for a non-transplant surgery, a brief overview of the immunosuppressive therapy and the common transplant-related complications. And then I will move on to specific anesthetic management of each organ transplant, surgery in a specific organ transplant like renal, liver, cardiac, and pancreas, a little about post-operative management, and I'll end up with a short summary. So as we all know, solid organ transplantation is the most established and the only treatment option for patients with end organ disease, and is, as we all know, it's increasing in number all over the world. In the US, in a period from 1988 to 2016, there were about 4 lakh kidney transplants, 1.5 lakh liver transplants, 64,000 heart transplants, and 33,000 lung transplants, which are huge. In India too, in 2019, we had performed the second largest number of transplants in the world, second only to the US. With improvements in surgical techniques, organ preservation, very good perioperative care, and advancements in immunosuppressive therapy, all this has led to very good outcomes and therefore improved patient survival. The 5-year survival amongst these patients is almost as high as 60 to 90%. So it is increasingly common for these patients, transplant recipients, to present for incidental surgery. So what are the kinds of surgeries that generally come for? It could be a post-transplant, related to the post-transplant surgery, early or late complications. They could be coming for elective diagnostic or surgical procedures, or for following trauma or other emergencies. So thorough preoperative evaluation and screening is essential and is very important in all the transplant recipients who are scheduled to undergo transplant surgeries. And we begin with getting a complete blood count and a coagulation profile done, which includes PT-INR, APTT, and platelet count. And why is this important? Because post-transplant anemia is kidney dysfunction, hemodilution, hypersplenism, immunosuppression therapy leading to bone marrow suppression, and some chronic viral infections such as cytomegalovirus infection. These patients may also have thrombocytopenia, which could be as a result of hypersplenism or the immunosuppressive therapy. So renal insufficiency is something which is very commonly seen in this group of patients, and 18% of liver recipients, 32% of heart recipients, and 20% of lung recipients, which is a huge number, will have some form of renal insufficiency. In addition, patients who are receiving calcineurin inhibitor therapy often progress to end-stage renal disease and will require renal replacement therapy, and this number could be as high as 29% at the end of 5 years. So for this, we need to have the baseline creatinine and urea and electrolytes such as sodium, calcium, potassium, and magnesium, some information about acid-base status. And all patients need to get a liver function test, but it is more important in patients who have had a liver transplant. Then cardiovascular evaluation is something that is absolutely necessary in this group of patients because coronary artery disease is highly prevalent. And the important thing here is that this coronary artery disease is not generally reversible following transplant. It stays. And they also have risk factors which predispose them to coronary artery disease such as hypertension, hyperlipidemia, and diabetes. The next, blood sugar hyperglycemia is often seen in this group of patients. One could be because of associated diabetes mellitus or because of steroid therapy. Then a little about the immunosuppressive therapy, just the broad points. And this is a common denominator in all the types of transplant recipients. And we have to balance the immunosuppression in such a way that there is minimal risk of rejection with minimal adverse effects and the risk of infection. So the first thing that we talk about is the steroids, which cause sequestration of CD4 T lymphocytes of reticuloendothelial system, and they cause inhibition of transcription of cytokines. And the common adverse effects associated with the use of steroids is hypertension, diabetes, obesity, and osteoporosis. Now, if the patient is undergoing a minor surgery or where the oral intake is not going to be hampered, the normal dosage of steroids can be continued. However, if the patient is scheduled for a major surgery or where the enteral intake or oral intake can be hampered, then these patients need to receive stress dose supplementation of steroids, which is usually 50 milligram of hydrocortisone every 8 hours for 48 to 72 hours, depending on the type of surgery and the when the patient is going to resume oral intake. And next we go on to the calcineurin inhibitors, which is commonly cyclosporin and tacrolimus. And tacrolimus is the drug which is commonly used in most of our patients. This actually binds to the calcineurin, which inhibits secretion of interleukin-2 by the T lymphocyte. The important thing to know here is that this group of drugs has a very, very narrow therapeutic index, and therefore they need to be monitored very carefully and are also associated with a lot of side effects such as nephrotoxicity, neurotoxicity, and glucose intolerance. They are also metabolized by the cytochrome P450 of the liver, and therefore all drugs which are metabolized by this enzyme system can affect the drug level of this group of drugs. Then some reports also mention that these drugs can prolong neuromuscular blockade, but practically we have seen it really doesn't affect the neuromuscular blockade so much. But however, in ideal circumstances, we can monitor neuromuscular blockade when these drugs have been administered in the perioperative period. And they need to be continued throughout the perioperative period. One should not discontinue them. Then anti-proliferative agents such as azathioprine and mycophenolate mofetil, they inhibit purine synthesis and cause suppression of T and B lymphocytes. The important side effect of these drugs is the bone marrow suppression, which leads to lymphopenia, thrombocytopenia, and anemia. And they are toxic to the GI tract and the liver. And these are also continued in the perioperative period. Then the mechanistic target of rapamycin inhibitors such as sirolimus and everolimus, they inhibit large molecule kinase activity with arrest of lymphocyte cell cycle. And they also can cause renal insufficiency, more so if they are given in combination with calcineurin inhibitors. Then these patients can lead to very poor wound healing and wound infection, and therefore these drugs are discontinued 1 week before the scheduled surgery and then restarted after 2 weeks of the surgery. One of the rare side effects of sirolimus is interstitial pneumonitis or interstitial lung disease, when they need to be discontinued. Then the two most common transplant-related complications are rejection and infection, like Dr. Sanjeev already mentioned in pediatric transplant. So rejection can be acute, chronic, or acute on chronic. And if you suspect rejection in the transplant recipient, all elective surgical procedures should be deferred. Excuse me. And the patient should be referred to a transplant physician. One should evaluate the proper function of the graft organ, as it can impact the functional reserve of the patient. And also, this can also lead to altered anesthetic drug pharmacokinetics and pharmacodynamics. Then infections in these patients are very common as a result of the immunosuppressive therapy, and they are at risk of opportunistic infections, the most common being Candida, Aspergillus, and cytomegalovirus. And the important thing here is that these patients will often not show typical signs of sepsis, so it becomes difficult to diagnose. And the rise in TLC is sometimes not very evident in these patients because of the bone marrow suppression or because of the immunosuppressive drugs. So sometimes becomes very difficult to diagnose, and you need to be very, very careful to look out for infections. Then the third transplant-related complications is the neurological complications, which can range from seizures to peripheral neuropathy to stroke. And this could be because of the immunosuppressive therapy, like I mentioned before, underlying fluid and electrolyte disorders, mostly magnesium and sodium. Then coagulation disorders, both hypercoagulability and hypocoagulability, can lead to neurological complications, such as ischemic or a hemorrhagic stroke, respectively. Now, broadly, the intraoperative management in most of these patients, the majority of these patients are administered general anesthesia, and almost all anesthetic agents and techniques are safe as long as you titrate the drugs to effect. And if you are worried about the hemodynamic stability, then etomidate is a good drug for induction of anesthesia. If there is ascites and delayed gastric emptying because of any reason, then a rapid sequence induction is advisable, and neuromuscular blockage should be monitored in case of patients who have renal insufficiency. Now, regional anesthesia is not contraindicated in these patients unless they have an underlying coagulation problem, and it can be administered safely. And in fact, it's preferred in patients who have undergone a lung transplant, because an intubation can actually disrupt or cause trauma at the suture line. And so if the surgery can be performed under regional anesthesia, that would be ideal. And if neuraxial block in a cardiac transplant patient might lead to hemodynamic instability, because these patients cannot increase their heart rate and are often dependent on the preload. So if you administer spinal anesthesia, they can often go into a severe hypotension. So one should be careful. And if you really do need to administer regional anesthesia, then an epidural or a low dose spinal would be a better choice than a regular spinal. Then whenever you are administering regional anesthesia, one should be very careful to maintain absolutely strict asepsis. And if you plan to put in a catheter for continuous infusion, then one should see that there is benefit of not introducing any infection. Then for neuraxial blockade, one should be careful to detect any osteoporosis or vertebral fractures, which can worsen the underlying neurological deficit. And one should ascertain and confirm the presence of peripheral neuropathy, because this could be attributed to the neuraxial blockade in the postoperative period. Then most of these the surgeries can be performed with standard monitoring, the standard ASA monitoring. And as far as possible, if not required, one should avoid unnecessary invasive monitoring. And these patients can safely undergo anesthesia with a large bore peripheral access and use of non-invasive hemodynamic monitoring, such as arterial waveform analysis. and transesophageal echocardiography. If you do need, if the surgery demands or the patient's underlying comorbidities demands invasive monitoring, one should be very careful to use a very strict sterile technique. And as far as possible, one should use an ultrasound to place all the invasive monitoring, especially for the CVC, because for two reasons. One, they might have underlying coagulation abnormalities, so the risk of complications increase. And second, often these patients will have repeated CVC insertions, so their anatomy might be a little deranged, and also the veins might have thrombosis. So to detect that, ultrasound would be ideal. Then if, as far as possible, blood products should be avoided in these patients, but because of many reasons, the most common being HLA allosensitization, which are the antigens which are present on the WBCs, which can initiate rejection or antibody mediated rejection. So the packed cells, if they need to be administered, should be leukoreduced. So because the antigens are present on the WBCs, and the risk of CMV is also there by when you transfuse blood. And as far as possible, the blood should be taken from a CMV seronegative donor. Also, the risk of TACO and TRALI, which is transfusion-associated cardiac overload and transfusion-related ALI, can be very common in these group of patients, and that, as far as possible, should be avoided. If you're giving random platelets, it generally is not associated with HLA sensitization, but pooled platelets might contain some amount of plasma. And if you need to give pooled platelets, one should use leukocyte filters. FFP and cryo can be given safely. So now we come to the individual recipients, transplant recipients. So first we deal with the renal transplant recipients, which is one of the most commonly performed transplant surgery. And one would think that once a patient is given organ transplant, a new kidney, the function is as good as normal. However, these organs have a lower GFR as compared to a normal kidney, to as low as 10 to 20%. 10 to 20% lower than normal, even though they might be having a normal creatinine. They also have a lot of associated comorbidities such as hyperlipidemia, hypertension, diabetes, and coronary artery disease. In fact, coronary artery disease is the leading cause of death in these patients in the first year after transplantation. So in the preoperative evaluation, one should have a good blood pressure and glycemic control. Electrolyte and acid-base status should be optimized. One should screen for underlying cardiovascular disease with a 2D echo or stress testing, or whatever is indicated. And the graft function should be ascertained by doing a urine analysis to look for proteinuria and the blood urea and creatinine values. So during the anesthetic management, the goal should be a renal protective approach, which means that you maintain adequate hydration. And adequate hydration does not necessarily mean overhydration. The over or underhydration both can be harmful to the transplanted organ. One should maintain mean arterial pressure more than 70 millimeters of mercury, or even up to 80 if the patient is a hypertensive, so that adequate renal blood flow is maintained. And nephrotoxic drugs should be completely avoided, and this is especially true for non-steroidal anti-inflammatory drugs, and they should be not given to these patients. So this is a systematic review which looked at post-operative outcomes of kidney transplant recipients who underwent non-transplant related elective surgery. And what they found was that the kidney transplant recipients had increased odds of post-operative mortality. And these odds was increased in the presence of diabetes mellitus. Acute kidney injury was the most frequently reported non-fatal complication, and this was highest following orthopedic surgery. So next we go on to the liver transplant recipients, and these could come in for surgeries early, immediately after transplant, which could be because of hemorrhage, hepatic artery and portal vein thrombosis, or bile duct anastomotic leak, or later for diagnostic imaging, endoscopic gastrointestinal procedures, or any other abdominal surgery following trauma or any other emergency. In the early post-transplant period, one should look at optimal management of coagulopathy and hemodynamics. The patient may continue to have extrahepatic complications of end-stage liver disease such as portopulmonary hypertension, pleural effusions, hepatopulmonary syndrome, and ascites, and these should be handled accordingly. Invasive monitoring in this group of patients and this early surgical complications is generally required, and the lines are often already there, so you don't need to worry about that. And the patients and the relatives should be explained about the need for post-operative ventilation and ICU stay in case of inadequate oxygenation. So later on, for surgeries planned and later on after 6 months, things that you should look out for are the cardiovascular changes, and the most common being hypertension. The incidence of post-transplant hypertension in this group patient is as high as 70%, and this is because of the reversal of the vasodilatory state. There is increased sympathetic stimulation because of if the patient is taking calcineurin inhibitors, and the mineralocorticoid effect of the steroids. Then coronary artery disease again is very common in these patients because of transplant-induced metabolic factors, like I already mentioned. And these patients can have perioperative acute coronary syndrome or congestive heart failure, and residual changes because of the end-stage liver disease like cirrhotic cardiomyopathy, pulmonary hypertension leading to impaired right ventricular function, or persistence of hepatopulmonary syndrome. Sometimes it can persist up to 1 year. So those need to be taken into account. So like I said, renal failure is extremely common, and the 5-year cumulative incidence of end-stage renal disease in patients who have undergone a liver transplant is 18 to 22%. And this risk increases in the presence of advanced age, diabetes, malignancy, high BMI, and if there is the occurrence of pre-transplant dialysis. So that increases the risk of CKD. So intraoperative goals in these patients should be appropriate dosing of drugs to prevent accumulation, optimization of the renal blood flow by maintaining the mean arterial pressure, and good hydration. So when we come to the intraoperative management, one should take into account that if the patient is scheduled for any kind of abdominal surgery, they can incur huge blood loss because of the previous surgery and therefore underlying adhesions, and good amount of blood and blood products should be arranged. One should take care that should not be overtransfusion, because overtransfusion and hemoconcentration can lead to graft thrombosis. Fluid therapy should always be goal directed to prevent both graft as well as renal dysfunction. All drugs should be titrated to effect, and ideally drugs with extrahepatic metabolism should be used, like atracurium. All inhalation agents have been used and have been used safely, but if available, isoflurane is the inhalation agent of choice because it incurs the minimal biotransformation in the liver of as low as 17%. Regional anesthesia can be given safely, provided there is no underlying coagulopathy. So now this study looked at, it was a retrospective analysis and looked at 96 liver graft recipients who underwent 144 non-transplant surgeries, and the median hospital stay was 4 days. So the most commonly performed surgeries were abdominal 22%, orthopedic 16%, and urological 11%. 70% of these patients were administered general anesthesia and the rest regional anesthesia or pseudoanesthesia. The common intraoperative events were blood product transfusion in 17% of patients, hemodynamic instability in 17% of the patients, and hypoxemia in 2% of the patients. About 13% of these patients were transferred to the ICU. 12% were discharged on the same day. 6% had acute respiratory failure. 5 had acute kidney dysfunction. 3 had coagulopathy. 7% had some sort of infectious complication. And 4% had rejection, and 4% died during the perioperative period. Excuse me. So next we go on to the heart transplant recipients. And the important thing in management of cardiac transplant recipients is to understand the physiology of the transplanted heart. And the thing that we need to remember is that the transplanted heart is completely denervated. All parasympathetic, sympathetic, and sensory innervation is disrupted. So there is impaired response of heart to the sensory input. although there might be an increase in beta receptor density, the myocytes are more sensitive to circulating catecholamines. So if you give catecholamines like epinephrine, there might be an enhanced response, and the myocardial contractility remains unaffected. The ventricular function is also preserved. However, the resting heart rate is increased because there is no parasympathetic counteracting influence, and the resting heart rate is often between 90 to 110 beats per minute. The increase in heart rate in response to hypovolemia or hypotension is blunted. So the heart is largely preload dependent. So the cardiac output is stroke volume into heart rate. Since the heart rate cannot be changed, so the stroke volume needs to be maintained or increased. Therefore, the heart becomes preload dependent to maintain the cardiac output. All indirect acting sympathetic agents such as ephedrine, phenylephrine are not effective. Direct acting agents such as norepinephrine, epinephrine, etc. are effective. Beta blockers have no effect on the heart rate and they decrease contractility, should be avoided as far as possible. Anticholinergics and anticholinesterase do not have any effect on heart rate. However, there are some reports of neostigmine causing bradycardia by activation of cholinergic receptors on the cardiac ganglionic cells, but these are rare reports. So if you're really worried about bradycardia, so one can use Sugama-Dex, which is a reasonable alternative, and you would not need to use neostigmine for reversal of neuromuscular blockade. The ECG oftentimes will show two P waves, one of the native atrium and the other of the transplanted atrium. And these patients may have bradyarrhythmias as well as tachyarrhythmias. Bradyarrhythmias are more common, and this is because of the surgical anastomotic factors, the anastomosis between the native atrium and the transplanted atrium, allograft ischemic injury, and chronic rejection. It's a sign of chronic rejection. And as high as 5% of these patients may need pacemaker implantation in the postoperative period. They are also prone to tachyarrhythmia. So what you need to remember about tachyarrhythmias, management of tachyarrhythmias, is that carotid massage, Valsalva maneuver is not going to be effective to correct supraventricular arrhythmias. Digoxin improves contractility but has no effect on heart rate. However, adenosine for control of supraventricular arrhythmias has an increased potency, so that the patient might have an enhanced response to adenosine and often have prolonged atrioventricular blockade. So the drugs of choice for management of tachyarrhythmias is amiodarone and calcium channel blockers. These patients also have a high incidence of tricuspid regurgitation. 17% of these patients after 1 year may have some amount of TR. Then one of the most important complications is cardiac allograft vasculopathy, which is accelerated fibroproliferative disease, which can affect the coronary arteries, and one of the major causes of mortality, and it could attribute to the mortality of 29% at 5 years. The thing is that this increases the risk of perioperative MI if you do not detect it early, and also becomes, if the patient does have a perioperative MI, they do not have typical symptoms of MI, the patient will not have chest pain, so sometimes the delay in diagnosis can be there. Then lastly, the pancreas transplant recipient, generally you need to look out for the end organ damage which is associated with diabetes, ensure adequate glycemic control, good metabolic and electrolyte balance should be maintained, volume status should be adequate. And one thing you need to ensure is where the pancreatic exocrine secretions are being drained. Is it into the bladder or into the intestine? If it's draining into the bladder, which is actually very rarely done, most of the times the exocrine secretions go into the intestine when it does not create any problem. However, if it drains into the bladder, a lot of sodium bicarbonate loss is there, which can lead to metabolic acidosis. So that needs to be looked into and corrected before surgery. Post-operative management, one should aim at early tracheal extubation for the reasons that prolonged tracheal extubation increases the chance of developing VAP. Post-operative ICU stay should be avoided as far as possible because ICU stay can predispose these patients to nosocomial infections, which is not desirable at all. So unless really indicated, they should not be transferred to an ICU. a good post-operative anesthesia is essential using a multimodal approach. And one of the good techniques is patient-controlled anesthesia with the short-acting opioids such as fentanyl in combination with paracetamol. And like I said before, NSAID should be avoided as far as possible in all this group, in all these patients. To summarize, transplant recipients actually have a kind of a chronic illness which affects physiological function. And as an anesthesiologist, one should have adequate knowledge of the post-transplant physiology of the patient, the associated comorbidities and their effect on the organ systems, then implications of the immunosuppression therapy, which is very common, and the need to continue them in the perioperative period. And based on this, one can tailor your perioperative management in this complex patients so that you have a very good outcome, post-operative outcome in these patients. Thank you very much.
Thank you, Dr. Bimi. It was a very comprehensive presentation. And basically, the take-home message is that we can choose any anesthesia provided we have the knowledge of the physiology of the denervated organ. Correct. And pharmacology of the immunosuppressants and their interaction with the anesthesia drugs and related comorbidities.
Yeah.
So now coming to a very upcoming topic in anesthesia, that is the impact of artificial intelligence on anesthesia and intensive care. Although artificial intelligence was in vogue for last 50 years or so, it's only in last 15 years that there has been a resurgence of interest, probably with the upcoming of electronic medical records, hospital information system, and data transmission modes, that it has gained so much of popularity. Our next speaker is Dr. Ashish Malik, and he's a senior consultant in Apollo Hospital. He has a fellowship in liver transplantation and also a management degree in health sector. Dr. Ashish.
Okay. Thank you, ma'am, for the kind introduction. And I hope my slides are visible on the screen.
Yes, Ashish, they are.
And at the outset, I would like to extend my gratitude and thanks to Dr. Jayashree Sood, Aneja sir, Dr. Radhakrishnan, and Dr. Sanish. And it's an honor and privilege to be a part of this webinar. So the topic which I would be taking you through for the next 20 minutes is the impact of artificial intelligence in anesthesia and intensive care, and the present and what the future holds for us. It's something which caught my eye when I was doing an MBA from FMS Delhi and into the field of data analytics and healthcare analytics. And I think I would be able to give a little bit shed some light on it. So to walk you through this talk, I have no conflict of interest to declare. And I would be talking about the definition of AI, how AI works, what has been the evolution of AI, why do we need AI, where and how, what are the applications in anesthesia or on our field, what are the benefits and the downsides for AI for our field, does the future hold anything for us, and the most important or the million-dollar question would be, will it replace us? So an interesting quote by Marvin Minsky, he is one of the top figures in development of AI. And so he said that the science of making machines do things that would require intelligence if done by men. So this is the first quote to start with. And if you look at the Wikipedia definition of AI, it says that the AI research is the study of intelligent agents. What do they mean by intelligent agents? Is that they perceive their environment and they are able to take actions which maximize their chances of successfully achieving their goals. Colloquially, the term AI is used to describe machines that mimic cognitive functions, as we humans do, that is learning and problem solving. So artificial intelligence, the buzzwords are AI, machine learning. AI is a component. The different subcomponents could be machine learning, computer vision, robotics, and language processing. Then is the development of machine learning. It is a subfield again of AI. What do you exactly mean by learning for a machine? It is by definition, a machine is said to be learning from the past experiences, that is, whatever the data is in, if its performance in a given task improves with experience. And machine learning can be divided into a supervised kind of learning, an unsupervised learning, and a reinforced learning. So just a bit about the history. John McCarthy was the father of the term of AI. Then Charles Babbage, Alan Turing, Marvin Minsky, they were key figures in development of artificial intelligence. The first thing which dates back is 1997, IBM came up with Deep Blue supercomputer. It could play chess and defeated Garry Kasparov. 2018, the board games, which were originally being played in China, and AlphaGo was formed by Google, and it was able to defeat Lee Sedol, the world number 2. The important point here is that this Go game had permutations of 10 raised to power 108. So that is where the machine was working against the human mind. And now at 2020, another AlphaGo 0 was able to defeat AlphaGo. That means the AI machines were able to play against each other without a human guidance. So with this brief history, just a brief cap on how the techniques in AI work, or how does it work? It's either a fuzzy logic, that the concept came in 1965, or it could be classical machine learning, and third was neural networks and deep learning. The figure gives us the first concept of fuzzy logic. You have the axon on the left side. The right side is basically a mathematical equation, which the AI uses. Then if you talk about the classical thing, you have an input of different variables. There is a hidden layer of artificial neurons, and you get an output. And if you talk about the deep learning, you have a multitude array of artificial neural network. You have an input, you have an output with barcodes, and there is a training set incorporated. As clinicians, these things may not be of matter to us, but if you look at the evolution of AI, from 1950s to 1980s, it was AI. From 1980s to 2010, it was machine learning, which began to flourish. Then it is now, from 2010 to 2020 onwards, it is deep learning and development of big data. So that comes us to a question of why AI. Basically, AI are trained systems which are able to take decisions. We have a human mind that is remarkably capable. It has remarkable cerebral talents, and we can understand logic, we can deduce, and by manipulation, I mean is that we come to an answer to a number of problems. But the human mind has fatigability, it can become slow, there is a cognitive laziness. We usually develop a term of shortcut mental work. We have a very tiny short-term working memory, and it's error prone. So initially we put all the data on the computers, which ultimately led on to big data, and that has led on to AI. Then why AI in anesthesia? In our field, our decisions cannot be postponed. Our errors in judgment are very prompt and starkly apparent. We have a specialty which has multiple elements of perioperative care, including the pain management and the ICUs. We have a specialty which is a mix of cognitive labor as well as dexterity-based labor. And what I can say is that this is the sharp end of the cause and effect. Any medical error or judgment can lead to death of the patient. So the patient safety and the outcome is of utmost importance to us. That's where the AI can hit. So what are the targets of this AI? We can use AI in the classification of the physical scores like ASA, the preoperative assessment workflows. We could control the anesthesia delivery. We could very well maintain the depth of anesthesia. Event prediction is an important component of AI. We could do ultrasound-guided procedures, pain management, OR logistics, electronic health records, and in proper and optimized usage of beds in the PACUs as well as the ICUs. So to understand the capabilities of AI, the areas which can be depicted is understanding human speech. That is the Google Translator. So when we are speaking to patients of different nationalities, which has now become quite relevant in our terms, Google Translator can be of great help. Then it will be competing at the highest level in strategic game systems. Then an important component called intelligent routing, that is in content delivery networks. Simulations could be a frontier for our education and training in anesthesia. And we could have autonomic functions or sensors, which is basically in the OR. If you look at the intelligent routing, what I mean to say is that we get some symptoms from the patient, they are routed to the data center here and this data center has a lot of medical books. Everything thing is devised into it. It makes a diagnosis. From the diagnosis, it is relayed to the patient, and to the patient then is advised about the lab tests. If it comes for surgery, there's a checklist formed. The checklist tells them or advises them about the date of surgery. Patient lands up in surgery. The procedures are delineated. Everything is happening at this, what you can say, the big data center or the big apple. And then ultimately the patient would be discharged and rerouted back to the home. So this is what is meant by intelligent routing. So AI is an important step towards it. If you look at the OR centers, this is a slide which is about a smart home. We have sensors everywhere. Just on a Google Assistant and a voice command, I can touch on to lights anywhere. So similarly can happen in the OR. We can tell we can give a command for the OR table to rise up, maintain the lights to certain levels, put up images. So that's the next step forward. And what is the present of AI in anesthesia? So this work has been going on and it has kept gaining pace since 2010. So the first thing was the development of decision support systems, that is the development of smart monitors. Then was automated assist devices, which is semi-automated anesthesia systems, the most important being development of closed loop systems called the CLAD or the MEC Sleepy. And then we could have procedure training by virtual reality. The next slide will tell you about the CLAD. That's an automatic control system which works on the feedback principle. It is a pharmacological robot, so it tells us the right drug at the right dose, the right time, and it integrates various expert systems. The Canadians brought MEC Sleepy into account. That was dubbed as the world's first robotic anesthesiologist. And the MEC Sleepy has controlling parameters like the BIS, the analgesia scores, or the TOF, the 3 phases of induction, maintenance, and emergence, 3 infusion pumps connected to the controlling units with the safety measures in place. If you talk about the next system, which AI brought, was Kepler intubating system. It was something with a robotic arm, with a joystick, and an audiovisual laryngoscope with the software control systems. So this has been used. Then, of terms of regional anesthesia, we had regional anesthesia stimulators developed by AI. One thing on the left shows you a diagram of axillary nerve blocks, the operator sitting in the room and trying to do the block with the AI. So it's a virtual reality. We could also get automated anesthesia carts. And something which is coming in the way, it might be developed by the Chinese in 2025, is the automated assessment of difficult airway with facial recognition technique. So we know that we are most of the times able to judge what is difficult intubation, but there are a number of instances in our career that we encounter a difficult air. So maybe this might be an answer to it. Then is the mobile, the real-time mobile tracking of the staff. That is, anesthesia is an emergency branch. Immediately, we could get in touch. People who would require intubation could just buzz and we would be there. So that's what is meant by mobile tracking. Smartphone anesthesia is also in vogue now. Then there's augmented reality that's called AR and AI. The combination of that helps in developing virtual anesthesia. 2015, the Canadians used this technology to give virtual anesthesia to a patient in Italy, and auto anesthesia could be the next step forward. So with everything about the OR, does the AI have an implication in intensive care? We have ICU patients. There is a big data here. Then the big data is transferred to the intensivist and he decides about the treatment. So if this big data is something which can be fed into a machine with an AI, it can give the intensivist a clue and he can take better decisions. So why do we need to predict, or what do we need to predict in an ICU? We need to predict the risk of mortality, the risk of readmission, the length of stay of that patient in the ICU, the early detection of deterioration. It's a very important concept. It could include the ward monitoring, and the best part would be diagnosing early sepsis. So how do we do it? There are 3 ways to do it. Either it's a part of a supervised training. You feed in a set of about maybe 2,000 X-rays to a machine, and that validates, it gets trained, and ultimately it gives you a diagnosis. So this is supervised learning. The second is unsupervised learning. The group's unsorted information, according to similarities, patterns, and differences, will be there without any prior training of data. Where has this been applied? We have been able to phenotype sepsis, 2018, phenotyping ARDS, 2017, and phenotyping hypotensive episodes, again 2017, with the help of AI. And if you come to what is the third part, that is a reinforced learning. That is a medical decision taken on the account of, for if you look at the diagram below, there are decision A, decision B, and decision C. It gets into the machine learning model, and the decision B gets the biggest star. So that means that is the most effective way to deal with a certain situation. And how it has helped is, it has been able to optimize fluid and vasopressor requirement sepsis, 2018. It has been able to optimize sedation and mechanical ventilation in 17, optimizing heparin dosages, which came at about 2016, and optimizing insulin dosage by Botatol in 2013. So these were the benefits which is happening due to AI in either the OR or in the ICU. But if you go in for the pro and con discussion, what benefits do we actually see? The journal by MIT said that the sedation with the AI machine costed about $150 to $200 for each procedure, and it was compared to $2,000 for an anesthesiologist being there. So leading on to cost reduction. Time reduction, of course, that's questionable. It's a service which is available 24/7. It can find out things which are invisible to the human eye. There is no inter-individual difference, and it can help in making us form a better clinical decision. All this is done with the help of something called as a predictive analysis. And what we are dealing is everything about the patient risk management. It could be, the predictive analysis can be either predictive, it could be either proactive, or it could be reactive, that reacts at the presence of the event. And proactive would be that it tells us at least 10 to 15 minutes in advance that this will happen. And that can be possible with AI. But the downsides, so what are the downsides with it? The errors can happen, and there's a huge learning curve. We're all learning, and it's just come into the picture. We don't want any wild responses. Then the quality of data matters a lot. The GIGO is a term that is called garbage in and garbage out. If you feed data which is of no value, then the decisions taken will also be of no value. There is an absence of emotional intelligence. There is no morality. The problem solving is limited. We still have to validate the safety and the efficacy on a real-time basis. The important thing is patient confidentiality. That is, if there is a data breach, that's a risk or a security issue. And we need a large subset of experts required. It's not only the physicians. So with this pro and con part of the AI, how has AI fared till now? On the right side, I want to show you something with the IBM came up. It was IBM Watson, which was devised in 2015, and an important cancer center in US, Sloan Kettering, was making clinical decisions for oncology treatment based on IBM Watson, but it is still being upgraded. There were some fallacies, and this fallacies occurred because the decision-making in medicine is complex and it's messy. It's not as simple as taking a decision for marriage. Maybe a decision for tattoo would be difficult because it's permanent for life. The meta-analysis on the CLAD showed us a significant reduction in propofol dose. There was a precisely maintained pre-established target BIS values with high performance scores. It significantly reduced the BIS. The system was able to give us a variable, maintain a given variable in a desired target range. But there were episodes of system overshoots and undershoots over its targeted value. This was a randomized control trial, as well as it was a systemized review published in 2017 about CLAD in anesthesia analgesia. So since I am interested in liver transplant, does AI have any role? I could come up with two recent articles. One was machine learning algorithms predicting graft failure after liver transplantation. And second was use of AI for predicting survival of individual grafts in liver transplantation. And after this, another paper which caught my attention, it's been published in February 17, 2020, is the effect of machine learning or AI-derived early warning systems for intraoperative hypotension versus the standard of care on depth and duration of intraoperative hypertension during elective non-cardiac surgeries. So how can that be helpful? I'm not be going into details of this paper, but it's quite interesting read. And since we are in the COVID times and we have been dealing with it, the AI has been used by the Chinese to develop a module where they could diagnose COVID-19 better. This is all about CT scans and finding out the CT pictures of COVID-19. And they say that it has been an absolute relish. So what is the future? what is the path breaking hope with AI? In anesthesia per se, we need a good data set, which gives us data about every second. Then we also need to know on the real-time basis, how does the patient become unconscious? Third is to have any immunological or hormonal measures. These variables are very important during surgery. So can we have something on that? Then the future could tell us about pharmacological variables about a drug, the exact flow profile, the timing, the pharmacokinetic profile, and about ventilation. It could tell us about the exact pattern and the timing of change and what exactly is happening. And since it's all about interventions, the procedure or the surgical, what is the impact of this intervention on the quality of life of a patient? But that leads us to a question that, is AI a threat to the anesthesiologist? So why are we scared about it? Is because it's a system which learns by itself. We have deep learning programs. The most commonly now being used is TensorFlow by Google 2018. It's unpredictable, therefore it can be said to be uncontrollable. But the next video which I'll show is the first point against AI overtaking us. So there's something which is called human dexterity and one thing called a machine dexterity. So this video shows two babies, a small infant and the other his brother. And on the left, you will see that the small kid tries to feed the other one. On the below, you have a patient and an AI machine on the right. So this is what is human dexterity is all about. And if you see the machine, if it tries to feed the patient, see what happens. So it keeps on doing. There's nothing to stop it. And because it's been programmed to do it. So this is something which the machine can do, but not us. And as the clip goes forward, this is a women's soccer team. The players are all humans, and look at the flexibility and the actions taken. On the other hand, we also have a soccer match of the robots. They're also playing, but this is what the machine dexterity is all about. So it's all programmed. There's nothing which the AI can overtake us with. The next one is a small thing about anesthesia. We have a robot on the left side. It's been given a task to fold a towel, and we have the anesthesiologist here checking the machine in the same time. So what I want to show you is that he's checking the laryngoscope now. He's loading propofol. And by the time the robot here on the left is just folding the towel, it's being programmed to do it. And in this time frame, the anesthesiologist is ready to shoot off with the anesthesia, and the robot is still folding the towel. So whether deep learning could overtake us, I have doubts about it, and this is what is required. So the next question is about the safety and complexity. We know that it's a complex thing to have deep learning. We have big data, everything is being analyzed, but safety is a big concern. And AI will be able to catch simple mistakes or stupid mistakes, but it can introduce new errors. The point to example was Boeing 747 or 787, the MAX 1, the two planes went down. That was all because of the defect of the AI sensor. Then the third point is that we need something like physicians, engineers, and machines. So hopefully not all surgeons are computer engineers. Otherwise, what they'll do is let's shut all the body functions and then start all over again. Then AI can predict. It's a predictive analysis. It is mathematical as well as logical, but everything is not predictable in medicine. We need to still adapt and evolve with this technology, because anything of an innovation at trigger first has a peak of inflated expectations. Then there is a trough of disillusionment. With that adaptation, we get some enlightenment, and there is a plateau of productivity. So this is how the AI will evolve later. And I end with the slide is there's more to anesthesia than just an eye. And anesthesia is an art, it's a compassion. And I don't think an AI would be able to overtake us, but it would be a great assistant to have. Thank you so much for patient hearing. Thank you so much.
Thank you, Dr. Ashish. Your lecture has added very valuable information on this topic. I just wanted to ask you just one question. What are the ethical issues surrounding the application of artificial intelligence in anesthesia?
The ethical issues here is that we have a machine. It's kind of something which is called clinical decision making. Not everything with the robot would understand would be translated into something which is a good judgment. There could be an error. The other ethical issue would be that we go in number of years of practice, seeing our juniors being trained, everything is being trained in front of the eyes. That human touch would be lacking. The confidentiality of the data, it's also an ethical issue, that can you share everything with it? Because nowadays we moved on from WhatsApp to Signal Lab just because that data breach could be a possibility. So these are some of the things. And the other ethical issues is that what about the workforce? That if we are trying to predict that there are certain fields which are, I don't see in anesthesia, it might be a big challenge, but in pathology, radiology, you could have people who are out of the job. So that is what I would feel AI should be able to address that before bringing such technologies.
And we should be able to inform our customers, that is our patients, about the use of artificial intelligence, that how it will add to our decision making.
Yeah.
Okay.
So thank you so much. So decision would be ours, but I think we will have a good assistant to tell us.
Just one more thing. Are there any clinical studies on the meaningful impact of artificial intelligence on patient outcomes?
See, one paper which has been just published, meaningful impact, I could say that AI in the echocardiography. That was one article which was published. And with the echocardiographic parameters, seeing to whatever things we manage in the ICU, looking at the clinical decisions. So that it has helped. But the other paper about intraoperative hypotension, see, if we see intraoperative hypotension, the first response is to give a vasopressor and bring the values back to normal. But in this paper, what they have seen is that they've taken a case of hypotension happening and giving Frenin and bringing the numbers back to normal, but the effect on bowel. Now, with AI, you could see it directly in front of the eyes. And if the bowel gets a little bit ischemic, so it enhances delays the post-operative recovery. So I think these things, the AI would give you a definitive idea rather than that means making us more profound and more scientific in what we do.
Do you think artificial intelligence has more diagnostic than a therapeutic value?
I think the diagnostic value is there, but I won't say it is more. I would say that if we have a big data, we have collated the data, not as a static value, but as a real-time value, but that's a big subset, then I think the therapeutic value would also be there. So diagnostic, yes, maybe I would say about 60-40, but therapeutic also, yes.
Okay, thank you so much.
Thank you, ma'am.
Two questions from the audience. One is from Joyce Nilima James. She's asking for the speakers to comment. The effect of post-transplant pregnant patient. What are the implications?
Yeah.
Post-transplant pregnant patient.
Yeah. Thank you, Dr. Murli, and an excellent question, Dr. Joyce. Actually, I wanted to talk about this, but because of the constraint of time, I couldn't. But the important thing you need to understand here is that all the anesthetic implications, which I mentioned, also apply to a pregnant patient, but with a little variation. These patients actually are allowed to get pregnant after about at least 1 year of transplant. And then the graft function is stable, the immunosuppression therapy has been titrated adequately. So after that, they are allowed to get pregnant, ideally. And moreover, because of the variation in immunosuppressive therapy, they don't get pregnant very easily. So the chances of infertility are quite high in this group of patients. But if they do get pregnant and proceed on with their pregnancy, the chances of them developing preeclampsia, hypertension, and other complications is much higher as compared to the non-transplanted population. And also the chances of adverse neonatal outcomes such as preterm delivery and certain neonatal congenital disorders are also higher in this group of patients. So coming to the anesthetic implications, patients with renal and liver transplants, as long as they have normal coagulation status, they can be administered regional anesthesia safely, as long as you remember the basics of the anesthetic implication, which I mentioned. However, in patients who have had cardiac transplant, in these patients, it would be advisable to administer a combined spinal epidural technique for a cesarean section as compared to a regular spinal, for the same reason that because they are preload dependent, sometimes that can precipitate sudden hypotension, which cannot be easily corrected. So when you do use a vasopressor, you have to remember the direct acting sympathomimetics will not work. So a nor-ADR infusion would be good. Phenylephrine can be used because it can increase the SVR and raise the blood pressure a little, but it will not cause reflex decrease in heart rate like it usually does. So that could be a problem, but otherwise it can be used in most of these patients. And the other thing, again, you have to keep in mind that they have a high chance of infection, so strict asepsis. So all the rest of the precautions remain the same. So this is largely, and sometimes what happens is because they might develop preeclampsia and nephropathy, so it becomes a little difficult to distinguish between a graft dysfunction or an underlying preeclampsia or nephropathy because of preeclampsia. So that becomes a little problematic. Otherwise, it is basically the same. Now, so if you ask me about my own experience, so I have done 2 cesareans for patients who had renal transplants. Both of them were stable on the immunosuppressive therapy and which was continued throughout their pregnancy. And both of them had cesareans for obstetric indications and were administered spinal safely, and there were no problems. Both to the mother and baby were safe. I have not done administered anesthesia to any of the parturients who've had either a liver transplant or a cardiac transplant, but yes, renal transplant I've had plenty of patients who undergo cesarean or delivery following a renal transplant. I hope I've answered your question, Joyce. Any other thing that you would like me to highlight, I would be happy to answer.
Dr. Vimi, I just wanted to ask you one question. So
Yeah,
supposing
sure.
you have a patient who has undergone transplant, probably kidney, liver, or heart transplant, and has come to a PAC clinic for some semi-urgent surgery, for example, hernia repair that is not obstructing.
Yeah.
What should be the minimum time lag between which you should choose before you take up this patient for surgery?
So a minimum of 1 year, like I said, like for generally you wait for
it is a semi-urgent surgery.
Semi-urgent, then see, for hernia surgery, semi-urgent, you really don't wait for 1 year. So you have to do it as early as possible. You explain to the patient the risks of undergoing an elective surgery in the background of transplanted organ. And I think with explained risk and taking due precautions of all the things that you need to administer and to monitor, you can take the patient for surgery. I don't think there is a problem. Because the patient comes with an obstructed hernia, the chances
the patient is not the hernia is not obstructed. It is.
No, you said it's a semi-urgent. No?
Semi-urgent.
So it must be a large hernia which can get obstructed. That's what the emergency is about.
And if it is a purely elective surgery,
then a minimum of a year.
Okay.
That's what.
Or till the graft function is stable.
Yeah, I'm happy to see that Dr. Achal Dheer is amongst the audience. And he's been putting his comments on the chat box. And he agrees with what you say, Dr. Vimi, that elective surgery has to be after 1 year in most cases. He has also added that sirolimus has to be discontinued for about 10 to 14 days before surgery. And you have to start monoclonal antibody in the perioperative period. And he also adds that when these patients come for surgery, there is a high risk of lymphoma. So there could be airway obstruction, which has to be looked for. And the other danger is osteoporosis.
Yes, so, absolutely agree completely. And I mentioned these points in my presentation also.
Yes.
So except for the lymphoma, which often these patients will be symptomatic if they have airway compression. So that needs to be ruled out. Yes. The presence of a lymphoma or a mass pressing on the airway needs to be ruled out. Right. And accordingly, the airway management will also differ. If the patient does have a lymphoma or a lymph node which is pressing on the airway, then one might need to do an awake fiber optic intubation in these patients.
Yeah, thank you, Dr. Vimi, and thank you, Dr. Achal Dheer, for putting your comments. And another question for Dr. Ashish. Dr. Raj, he's asking whether there is any legal implication of artificial intelligence.
Okay, and thank you, Dr. Raj. Incidentally, he's been my senior in Maulana Azad, and he's talking about the legal implications. I would talk you through the point that we had something called supercomputers. Then the computers came with the development of machine. Then you have laptops, you have desktops, and finally you have a smartphone. So it's all about evolving. It's all about adapting the technology. The same thing is that we do a surgical procedure from an open surgery to a laparoscopic surgery to a robotic surgery. So when you get these AI intelligent devices with that, the only thing is explanation, making the patient aware, like an informed consent. And the legality is that it's not that the machines would do everything. And it's like the whole, if they create a problem, it's not like that the whole blame would be on the anesthesiologist. It is, as I said, it will be an assistant to us, but it would never override us. So I think that legality within the terms can be defined, and we can go ahead with the patient care as it would be.
Yeah, I think even our laws need to evolve to, address these issues of artificial intelligence, isn't it?
Yes, yes. It's similar thing like you use Google Maps. The routing is there, so it's like a patient routing, which I think they are practicing this now in Stanford and the places which are actually moving ahead in the AI.
Right. Thank you, Dr. Ashish. I have a question to Dr. Aneja. This question is that most of the liver centers in this country are regulated. They're given a license by the ministry. So do they have a separate license for pediatric? And should all hospitals which are doing adult transplantation, should they be allowed to do pediatric transplantation?
Legally, there is no separate authorization for pediatric liver transplantation. If the NATO has given you authorization to do adult liver transplantation, you can do pediatric liver transplantation. But on the other hand, since it is a specialized field, probably you need a special training. And I don't think anybody who does not have a trained team should try to do pediatric liver transplantation. But legally, there is no stoppage.
So you mean to say maybe they should develop some referral centers which take in pediatric, not only pediatric patients, but also train other people, so that other people get trained before they start doing these bigger things.
Absolutely. I think it is developing now. Initially, a lot of centers were doing pediatric liver transplantation. Now it is getting concentrated in few centers. And there is also getting more experience, and it is absolutely different. The surgeons need training in the pediatric liver transplant. The anesthetists need training in the pediatric liver transplant. And gradually what you are saying is happening nowadays. Nowadays, pediatric liver transplantation is getting concentrated in few centers.
Right.
Excuse me, sir. Sir, I have a question for you. Sir, how do you manage perfusion of adult kidney in a small child with regards volume and selection of IV fluids?
Okay.
Actually, we are really, it's a very confusing thing. So we keep on jingling things in this.
Adult kidney, if placed in the retroperitoneal space in the older children, probably it is not a big problem. But adult kidney, if it is placed intra-abdominally in a small child, less than 5 years or less than 20 kg, it is a big problem. There are problem of two things. First, hemodynamic problem. You have problem in the clamping of aorta and IVC, which can result in fall in blood pressure. And when you open the IVC, there could be reperfusion. And secondly, what happens that the abdomen is a big organ. That kidney becomes a mobile organ. It is very difficult to fix the kidney. The kidney is found all over, and that is another problem. But on the whole, these kidney, because they can take a lot of cardiac output from the patients, you need to give fluid and blood a lot in these patients. And that is what I said, probably they need so much of fluid and blood, they become fluid overloaded, and smaller children probably would need post-operative elective ventilation.
What would be your fluid of choice, sir?
Nowadays, the trend is going for this balanced fluid.
Okay.
In pediatric as well as adult, the trend is towards balanced fluid. I am not in favor of giving albumin a lot, but yeah, balanced crystalloid along with blood products.
And if we needed an inotrope, what would be your inotrope of choice?
My inotrope of choice would be norepinephrine.
Okay, thank you, sir. Just one more question, sir. Do you have any experience with ABO incompatible kidney transplants in pediatric patients?
Yes, we do. We have done a few ABO incompatible in pediatric transplantation. In pediatric, they are not a big problem.
Thank you, Dr. Aneja. And I have a comment to make with respect to artificial intelligence, Ashish. The thing is that in a country like ours, where there is a huge disparity between the patient load and the doctor-patient ratio, which we have very few resources and a huge patient load. So do you think that artificial intelligence may play a role in greater access? With the lesser number of people we have, we are empowered to do greater number of things in the sense that you could access a larger population. It could help you make decisions. It could help you make diagnosis, or even prevent certain problems which are happening with the decision making which the doctors are making. So do you think there is a role in that?
Sir, thank you for this question. Actually, what you're saying is entirely correct. And Google, with its headquarters in US, has been coordinated with few Indian centers dealing with some problem like diabetic retinopathy. And it's purely based on the same issue that we have very few doctors who are trained in this field. There's a wide gap of coming to terms with the diagnosis. And with the help of AI, they have been able to diagnose the development of diabetic retinopathy earlier, get them to some doctors. And since AI has very limited scope of errors, if you see in such diagnostic fields, and I think in a country like ours, which is the length and breadth itself is long, plus the deficiency of medical services, and I think AI can really play a role, and ultimately it can lead to a better quality and help in preventive health. So I think AI has a role there.
Okay, thank you. And there are a few comments which are not actually questions, but Dr. Lalita is commenting that about one patient who is post liver transplant, got pregnant and was operated under spinal, and everything went well. So there are a few comments like that, but no particular questions.
I have a question for Dr. Vimi. Dr. Vimi, are there any clear-cut guidelines regarding thromboprophylaxis in post-transplant patients intraoperatively?
Intraoperatively?
Perioperatively?
Yeah, it's the same actually for...
no difference?
It's the same for any other surgical patient. And as long as the patient has normal graft function, they're like normal patients. If they have deranged graft function, like if the patient has had a liver transplant and the graft is not functioning well, so you treat that patient like an end-stage liver disease or compromised liver function, and then a TEG would be a better measure of the coagulation status, and you monitor and titrate your therapy according to that, instead of the regular coagulation parameters. Otherwise, if the graft function is all right, I think you just treat them like normal surgical patients.
And do you routinely give stress dose steroid prophylaxis in these patients?
Yes.
Even if they have taken their routine steroids?
If they've taken their routine steroids in the morning and
yeah.
They are likelihood of them resuming their oral intake the next morning, then we don't give any stress dose steroids. If they are unlikely to resume their oral intake, then we follow it up with steroids. And previously the guidelines, what the guidelines said was 100 milligram etarly, but now it has been reduced to 50 milligram etarly because that much steroid is not really required. And that too, if the patient is on more than 5 milligram of prednisolone every day, per day. If it is less than 5 milligram, then we don't give stress dose supplementation.
And if you have a post-transplant renal patient for surgery, what hemoglobin would be acceptable for surgery, for elective surgery? Because of the increased prevalence of post-transplant anemia in these patients and hazard of blood transfusion.
Correct. So if the patient has post-transplant anemia and a selective surgery can wait, then we try to build up the hemoglobin by using other measures like giving erythropoietin or by giving iron, so that we don't need to give blood and blood products. So if the patient has time, definitely we would like to bring up the hemoglobin to ideal at least 10 gram % in Indian circumstances. What the Western standards say, it should be a minimum of 11 gram %. But we usually, 10 is quite all right for us. So we use other methods. If it's not coming up, then definitely Paxils will need to be given.
Okay, thank you.
So I can't see any more questions on the chat box.
Right. Thank you. Right. Yes, Murli, I think we are done with most of the questions and the comments. So should we wind up then? And can I just conclude the session, Murli and Archana?
Yes, ma'am.
So thank you very much. It was such an interesting webinar, so enlightening to all of us. And, we had all the faculty they were speaking from their heart, because it's these topics and these specialties are so close to their heart. So really it was just coming naturally, and we gained so much from their talks and the moderators as well. And I'd like to thank Dr. Murlidhar, Dr. Archana Kaul, Dr. Sanjeev, Vimi, and Dr. Ashish for this excellent webinar. And thanks a lot for accepting it. And I would also like to thank Dr. Rahul Chobe for the Anesthesia TV, the live streaming that is done every week. And thanks a lot, Rahul. And thank you very much, Sanish. Next week, we have another seminar on the medical legal implications, which is going to be more like a panel discussion. So it's going to be very interesting for the students and the practitioners as well. So thanks a lot, everyone, and good night, and have a good
Thank you, ma'am.
Thank you.
Thank you, ma'am.
very much.
Thank you, Dr. Murli and Dr. Archana.
Thank you.
Thank you.
Thank you, Vimi.
Bye.
Thanks.
Good night.
Thanks,
Nice
Archana.
meeting you.
Sanish. Thank you, Sanish.
Thank you. Thank you, Sanish.